Hello, this is the Dental Protection Podcast. My name is Dr. Alasdair McKelvie, and this is the Spotlight on South Africa series. So, in today's podcast, we'll be talking about clinical error, scope of practice, scope of competency in clinical practice. And joining us today once more, we have Dr. Jacobus Bernard and Dr. Yash Naidoo. So, welcome, guys. Let's get the conversation started. And Jacobus, specifically in your role as the SADA mediator, disputes that you mediate between unhappy patients and clinicians relating to clinical aspects of treatment, and there are quite a lot of those, suggest that as clinicians we don't always get the treatment right, and we're human after all. When things go wrong, would it be fair to say that because we're proud of our work and we never try to do a poor filling or fit a poor crown, but things just go wrong, do you think that we're actually good at dealing with poor clinical outcomes and actually discussing those things with the patient? Or is the communication, again, an obstacle when things have gone wrong?
Thanks, Alasdair. Hi, everyone. Yeah, so what I see on the one side is a failure to meet the patient's preoperative expectations, especially with prosthetics, orthodontics, and implants. But then on the other side is a failure or an unwillingness or an inability to address the post-operative complications when things does go wrong. To be more case specific, good examples is, for example, with dentures. When a patient can't tolerate that new set of dentures despite the dentist relieving, relining, and eventually redoing the whole denture. So the dentist gets fed up with this demanding patient, and the patient don't want to pay for a product they can't use. So then you have a dispute. Then with endo, like we said in the previous podcasts, we have a lot of file separations where you need to involve an endodontist to try and retrieve the fractured instrument. Or some patients lose that tooth and needs to have it replaced with an implant. Who pays for it? Who pays for the file removal or the implant? And then with orthodontics, GDPs taking on treatment, diagnosing and treating a patient incorrectly. And in the end, when things don't go according to plan, end up with an orthodontist that changes the whole treatment plan. Who's going to pay for the specialist treatment then? Crowns that fail in a short period of time that perhaps should never have been done. And we talked about generic consent forms. Those dentists, the first thing they give you when you ask them about a crown that only lasted 6 months is a generic consent form, and say, look, but the patient signed a consent form. So yeah, implants, they're being placed in unrestorable positions. And, fillings, the patient didn't have any symptoms before going to the dentist and now require a root canal treatment or an extraction. Then you have a dispute because the patient can't afford a root canal treatment. Surgery when there's just post-op complications and the dentist, like I said, is unwilling or unable to treat the post-operative complications. And that's a sort of things that creates disputes and the things that I see daily in my inbox.
Okay, so here is the big question. Okay, so you talk about your inbox, and that's where the patient they either phone you up, I guess, or they send you an email saying I'm unhappy about my dentist. Okay, I'm presuming, and Yash can maybe help me out here, because one of our professional obligations, one of the ethical rules says that you must deal with patient complaints. So it's like a professional obligation. But when the patient contacts you, I am presuming you say to them, have you told the dentist that you're unhappy with the treatment? Okay. And then when you contact the dentist and tell them you've got this patient complaining, are they generally aware that the patient's unhappy, or is there a big surprise here? So there's two parts to that question. There's the first one: have you made the dentist aware you're unhappy from the patient? And then when you go and contact the dentist, how many of them know the patient's unhappy, or how many of them haven't been made aware? What's going on there?
Yeah, so we always encourage self-resolution and always try and make sure that the dentists are aware of the patient's problem and given an opportunity to resolve the problem without the involvement of third parties. Most dentists are aware of the patient's problem, or their staff. You know, when you phone them up to speak to them about the patient, they go, "Oh, I know Mrs. Jones," you know, things like that. So most of them are aware of the problem. But sometimes the dentist isn't aware of the problem because the receptionist never informed the dentist about the problem. And that highlights the need of a practice complaint procedure, because if you don't want to be surprised by a health professional counsel letter under your door, you should be aware of every disappointed patient in your practice, because it's very easy to complain to the health professional counsel. It's a path with very little resistance.
And so is gathering website feedback as well. On the internet, everybody likes 5 stars, but occasionally they get 1 star. Yash, and I'm going to come to you on the 1 star feedback. I mean, we don't take criticism particularly well, do we? When we get a 1 star feedback, I mean, is there anything that you would recommend folks do if they get a 1 star rating?
Thanks, Alasdair. Good to be with you both. You see, with modern society comes the pros and the cons of social media and Google reviews or any other reviews. It's human nature for us to accept and gladly take the 5 stars, but when we do see the 1 star, to get a bit taken aback. One can argue that in essence, a 1 star review is technically a complaint. And as you've mentioned earlier, it's good practice to not simply ignore a complaint and hope that there'll be a million more 5 stars that'll bring your rating up. But it would be worthwhile to, if possible, get in touch with a patient. I wouldn't recommend publicly getting in touch with them. I would recommend perhaps a generic response to say along the lines of, we take patient service very seriously and please get in touch with us at XYZ address so that we can help and investigate. But yeah, as you've mentioned, take complaints seriously and see them as a learning curve. You can always develop your practice.
Yeah, and while we've got you speaking here, Yash, I just want to. I mean, I don't know the answer to this, okay? But what I'm increasingly seeing generalists undertaking more complex treatments in South Africa, and certainly more complex elective restorative work as well. We're seeing things go spectacularly wrong, and we've got the scope of our profession, but we've also got our own scope of practice or competency. So we have this situation in South Africa where, as a generalist, you can undertake any procedure, providing you meet the requirements of Ethical Rule 21. Can you just explain to the guys listening what Ethical Rule 21 means to us?
Yeah, perfect. So Ethical Rule 21 is an important rule and perhaps subject to a bit of subjectivity, but let me just read it out to you first. So it says that a practitioner must perform, except in an emergency, only a professional act, 1, for which he or she is adequately educated, trained, and sufficiently experienced, and 2, under the appropriate conditions and in appropriate surroundings. And you'll see why I said that it's sort of subjective, in that somebody would ask, well, what is adequately educated? What is adequately trained? What's sufficiently experienced? And this is where the rule comes into a bit of contentious issues or gets involved in contentious issues. But this is also where I think the regulator plays an important role and can give guidance. And to their credit, the HPCSA, for example, in the case of oral hygienists, put out a few years ago, I think it was a bulletin or something to that effect, which said that oral hygienists are allowed to do tooth whitening, provided that they're adequately educated and trained, and it quoted the rule. But the professional board went on to elaborate about what training is. And what they said is on-the-job training and attendance at CPD events is not enough to satisfy that requirement. So I tip my hat to that board for going out and explaining further in respect of that rule. But the problem will always arise is that, as we know, there'll be unique cases coming up in future. And that question will always arise. Were you adequately trained, sufficiently skilled and experienced to do the procedure that you did? And if not, should you reasonably have referred them to somebody else? So that's the rule, and that's the issues that's come with that rule.
Yeah. And the problem inherent in all of this is that essentially we're regulating ourselves, aren't we? I mean, we're applying Rule 21 to ourselves, and maybe as the clinician here, I'm going to pass this next question to Jacobus, but it's not as if somebody's watching what we do in the surgery every day, and it's not if somebody, once we leave university, nobody's marking our cavity preparations, our impressions, the fit of our restorations, how good our endos are, whether we use rubber dam or not. This is down to professionalism and self-discipline and how you measure. But, Jacobus, you've talked about how many years you've been in clinical practice. How do you know when you've got the skills to approach the management of complex dentistry, whether it's complex dentistry because of pathology and disease, or complex dentistry because the patient comes in and says they want a smile makeover and they want to look like so and so? I mean, how do you know when you're ready to undertake that sort of work? How would you measure yourself in your experience?
Yeah, thanks, Alasdair. Yeah, look, it is a very difficult question. I'm a GDP and I place implants and I do my unconscious sedation. And I've been a dentist for just under 24 years. And as we discussed in our previous episode, where things have gone really wrong for me when I tried to remove impactions in theatre with 20 years experience, it is a very difficult question, is what makes you adequately educated and trained for a certain procedure? Is it a weekend course, or is it a 2-year postgraduate diploma with the university? Or do you need to be a specialist with the MCHD from the university? For me, a big problem is the reps of certain companies that puts pressure on clinicians to do procedures like place implants or do rehabilitations, full mouth rehabilitations, because they sell more product. And these reps are often present during the patient assessment and in the surgery while the procedure goes on, and they advise the dentist on what to do. And for me, that's a big predisposing factors. The dentist should be the expert, and that's why the patient came to see him in the first place.
Once you go on the register as a dentist in South Africa, you can do, as a generalist, no matter how good you are or how bad you are, you can undertake just about anything, any procedure. And I don't know if you guys want to comment on this, but increasingly I am dealing with complaints and claims where the patient thinks they in their mind they have a specific treatment that they want a dentist to provide, and a lot of this stuff is the elective aesthetic work, okay, where people are thinking this is going to change their life or whatever. And there was one case recently where the patient asked for a complete makeover, and she was going to go back and win back her boyfriend with this new set of teeth. So there's a lot of vacuous stuff out there. There's a lot of people think this solves all of their social problems, but it doesn't necessarily do that. But what I am seeing patients do is I'm seeing them shopping around, first of all, for a treatment plan, and maybe from a specialist, getting the treatment plan from the specialist, and then shopping around, going to various generalists, and they actually might not even ask their own dentist to undertake the procedure, but they'll go around until somebody says, yeah, I'll do that, and I'll give you the discount that you're demanding here. So the behavior of patients is unusual in this space, but also what we're seeing is we're seeing generalists agree to undertake complex procedures and cut corners because they've agreed to do the work for far less than the patient was quoted by a prosthodontist, run into problems, and things very quickly get out of control. Is that something that you're aware of happening here? Is that we're seeing more and more generalists taking a chance to do more complex procedures, because otherwise they'd be sitting with an empty chair, no patients in them?
Yeah, Alasdair, I'm also a GDP, and so it is difficult because on the one side, you want to learn new skills and offer new services to your patients and grow yourself as a dentist. So you want to try and push the boundaries, and in a way, that's the only way you can learn is by making mistakes. But on the other side, what me and you and Yash see every day is dentists taking on treatment way outside their ability and their experience, and then run into trouble. And so it's that balance between trying new procedures and pushing yourself to learn new skills, but realizing where to stop and when to refer. And that's what experience would tell you.
So presumably, patients who are treated by specialists must be unhappy at some point about their treatment. Do you receive complaints about specialists or not? And if there are fewer complaints from patients who have been treated by a specialist, why do you think that is?
Yeah, we receive complaints against specialists, but they're more fee-related. Specialists are even worse than dentists when it comes to financial consent. So the complaints against specialists are more about the fees and not as much about the clinical treatment.
And presumably, Yash will know this, but I've yet to see a problem involving a patient where they've been to see somebody who's got a practice limited to endodontics, and the fractured instrument is the problem because they've got the skills to manage that complication, and they get the fractured instrument out. So it never ever becomes a problem. But I think that is the key to dentistry. Sometimes dentistry is incredibly complex, and sometimes things don't go the way that you want them to. And it's that ability to recognize there is a problem, stop, reset, and refer to another colleague. And I think, where do you go? Dentists nowadays have a different mindset, okay? But what do you recommend people do to develop the skills and the competencies that they're going to need to do the complex treatments apart from train as a specialist?
It's always a good idea to work under or with a dentist that's got sufficient experience and a passion for what he's doing, and belong to peer review groups and just continuously learn and strive to improve yourself and realize your limitations. Like Alasdair said, when you're in a situation where you're not sure, always fall back to that ethical principle of if this was your child or your mum or your dad, what would you have done in this situation? And then really treat patients with that in the back of your mind.
I think, nowadays having a coach or a mentor is key, and I was coming to Yash here about this whole idea of a coach or a mentor, and I guess for a couple of weeks I might have been your coach or mentor when you signed up with MPS, but we all need somebody that we can say, this is not working out right. Is that an experience you've had, Yash?
Yeah, fully agreed. Always good to have a coach or a mentor. Bear in mind, the patient will need to know if you're involving somebody else, so you'll need their informed consent on that. I just wanted to add one little bit of extra onto what Jacobus had mentioned, is that if you're going for training, ask the people that are giving the training whether they're HPCSA accredited, and get some sort of written confirmation in that regard, because the HPCSA have made sort of proclamations on this in the past. So always good to check and see if they're accredited.
Guys, thanks very much. And with that final point from Yash, we reach the end of today's podcast, and in fact the end of our series Spotlight on South Africa. It's been really interesting. It's been great having both of you on as guests. I've really enjoyed that. There's lots of other topics I think we can explore that will be of interest to our colleagues in South Africa. So thank you for your thoughts. Thank you for your time and your contribution to this series. If the listeners would like a certificate to go towards your CPD from listening to this podcast, or to learn more about what we've covered today and who you were listening to, then please do take a look in the podcast description. I've been your host across the series. My name's Alasdair McKelvie. Thank you very much for listening. I hope you've enjoyed that.